Hi, welcome to my classroom. In this today's lecture, I will be talking about ascites. Ascites means collection of fluid in peritoneal cavity. These patients, they are very common in outpatient department. These patients, they present with distension of abdomen. Abdomen is distended. So, whenever a patient comes with distension of abdomen and you are suspecting ascites, that is collection of fluid in abdomen, then one must go step by step in clinical history taking so that you can reach a perfect diagnosis. So, in clinical approach, first thing which comes in our mind is what's the cause of this ascites. So, to detect the proper cause, you will have to approach step by step. First of all, in history taking, if you are asking history of the patient, if you are interrogating the patient, in that you will have to first inquire whether that ascites is of acute onset, that is sudden onset, it is of insidious onset, or it is of chronic type, it is long standing. The acute ascites, which is of sudden onset, this type of ascites is usually seen in conditions like acute Budd-Chiari syndrome. In right heart failure, in these cases, the ascites which develops is of sudden onset, or if there is sudden decompensation of compensated cirrhosis, then also the ascites suddenly develops within 4 5 days. If patient is presenting with acute pancreatitis, in those cases also there is sudden onset of ascites. Inside ascites may accumulate in peritoneal cavity, that is fluid may accumulate in peritoneal cavity insidiously, slowly. This type of ascites is usually seen in decompensated type of cirrhosis. There is gradual accumulation of ascitic fluid. In dilated cardiomyopathy, there is gradual accumulation of ascitic fluid. In myxedema, that is hypothyroidism, there is gradual accumulation of ascitic fluid. In cases of nephrotic syndrome, there is gradual accumulation. It is not of acute type. In cases of tuberculosis, Cox abdomen, there is gradual accumulation, insidious accumulation of ascitic fluid. So, whether the ascitic fluid is sudden onset, or it is chronic or of insidious onset, you will have to decide from history. It is very clearly evident from the history. Then always inquire whether there is associated pedal edema or not. If there is associated pedal edema, then it is usually suggestive of nephrotic syndrome, because in nephrotic syndrome usually first pedal edema develops, facial puffiness develops, and then later on ascites develops, while just a reverse happens in cases of liver disorders. But actually in clinical practice it is not so. The mixed type of picture is usually seen. So first inquire about these things. Number 2, inquire about any history of jaundice. If jaundice is present, if there is history of jaundice, patient is giving history of jaundice, then it definitely suggests that pathology is lying in liver. There is either some chronic hepatitis or cirrhosis, or even in Budd-Chiari syndrome, patient may present with jaundice. So severity of jaundice you can assess further by clinical examination, but from history you can inquire about the jaundice. If there is presence of jaundice, then definitely it indicates that there is some problem with liver. Then in the next step, to rule out the cardiac causes, you will inquire about breathlessness. If breathlessness is progressive, if there is development of ascites which is progressive, gradual distension is there, insidious distension is there, if there are other features of other cardiological manifestations of valvular heart disease, then this all suggests that heart is affected. Usually in valvular heart diseases, patient may develop ascites. In tricuspid regurgitation, patient may develop ascites. In dilated cardiomyopathy, in pericardial effusion, on all these conditions, patients may develop ascites. So this is insidious type, and there is no history of jaundice, But in later stages, even in cardiac ascites, if there is cardiac failure which is long standing, again in that jaundice can develop because of hepatic congestion. If patient is having nephrotic syndrome and if he develops ascites, then again in history you will get features of involvement of kidney. You will get evidence of kidney disease. If there is, you may get evidence of diabetes, hypertension, which has lead to the involvement of kidney. So always rule out involvement of kidney if the ascites is of insidious onset. So one by one, stepwise, you will have to go. If there is history of cold intolerance, of chronic constipation, if patient is having pedal edema, if he is having puffiness of the face, hoarseness of voice, this all goes in favor of hypothyroidism. So you can say from history that probably there is myxedema, and myxedema has led to this ascites, fluid collection. Again, this is insidious. In cases of tuberculosis, suppose if you are suspecting tuberculosis, then in that case you will get history of either pulmonary tuberculosis in the recent past, or you will get history of gradual weight loss, evening rise of body temperature, and gradual weight loss. You will get history of gradual weight loss. You will get history of lethargy, weakness. All these things will be of chronic type in cases of tuberculosis of abdomen, in Koch's abdomen. It is also known as Koch's abdomen. So one by one, like this, you will rule out each and everything from history. Then after that, you will move on to the clinical examination of abdomen. In clinical examination of abdomen, when you will examine the abdomen is distended, and whenever there is collection of fluid, the distance between xiphisternum and umbilicus is more than that of xiphisternum and pubic symphysis. So this above distance is more in cases of ascites. And if there is some tumor in the lower abdomen, then the distance between umbilicus and pubic symphysis, that is lower distance, is more. So here the distance will be more in cases of ascites. So in clinical examination, first in inspection, you will see that what type of ascites it is. That is, assess the distance between xiphisternum and umbilicus. Then you will move on to see the free fluid in abdomen. So there is free fluid in abdomen. You can definitely elicit the sign of the shifting dullness in free fluid. And if fluid is less in amount, then a puddle sign is there, in which you will say patient to go on the knees, and then you will percuss the abdomen. So these are the few signs which are elicitable in the cases of ascites. Apart from this, in clinical examination, you will see the general appearance of that patient. In the general appearance, when you examine in general way the whole body, in that case, if suppose it is a tuberculosis, then you may get its focus in the eyes. You may get a triangular type of patch immediately in the eyes. This is usually a reaction to the tubercular protein, and this is seen in cases of tuberculosis anywhere if tuberculosis is present in the body. So in the cases of tuberculosis in eyes, when you will see, you can see this patch, thick patch of mucosa immediately in the eyes. Then watch for the you can see the lymph nodes. In the lymph nodes, if cervical lymph nodes are enlarged, again they are suggestive of either some abdominal carcinoma, some malignancy in the abdomen, or tuberculosis. So examination of lymph nodes, examination of eyes. In eyes, if jaundice is there, icterus is there, then it is again suggestive of liver disorder. It is suggestive of chronic congestion of liver. If there is pedal edema, then it goes in favor of again nephrotic syndrome. If it is non-pitting type of edema, that goes in favor of myxedema, that is hypothyroidism. So one by one, like this, you will have to see. If there is generalized wasting, then again it is going in favor of cirrhosis, alcoholic cirrhosis. In general examination, you can see the peripheral signs of alcoholic cirrhosis or cirrhosis, like spider nevi palmar erythema, Dupuytren's contracture, gynecomastia, atrophy of testes. These are all features in general examination. You will have to see for anemia if patient is anemic or not. When you examine, a special thing is examination of neck veins. If neck veins are engorged, then that is suggestive of cardiac pathology which is causing ascites. If there is ascites but neck veins are not engorged, that excludes cardiac cause. So examination of neck veins is must in these cases. So like this, you will go step by step in the clinical approach of ascites. So like this, you will do the clinical examination. Then after the clinical examination, if there is ascites, then you go for USG of abdomen, that is ultrasound of abdomen. In ultrasound of abdomen, you see this collection of fluid. You can see the collection of fluid in peritoneal cavity. Ultrasound can detect about least amount which can be detected with the help of ultrasound is 100 ml of fluid. After that, assess the condition of liver. What is the echo texture of liver? In cirrhosis, echo texture of liver is deranged. It becomes coarse, it becomes nodular. So you see the echo structure of liver. You will have to see the condition of portal vein. If portal vein is less than 10 millimeters of mercury, that is in favor of portal hypertension. If there is surrounding dilated venules around the portal vein, then it is suggestive of portal hypertension. If there are lymph nodes, that goes in favor of either carcinoma or tuberculosis. So you will have to assess liver in a proper way, liver architecture, ultrasound architecture in a proper way. Apart from this, then you will go for examination of spleen. If there is splenomegaly, that is again in favor of portal hypertension. If liver structure is normal, echo structure is normal, and if peritoneum is thickened, if there are lymph nodes in the peritoneum, then you will have to exclude tuberculosis. Plus, you will have to exclude metastatic carcinoma. You will have to find the primary in the abdomen or elsewhere, wherever it is. So like this, also USG of abdomen is very helpful in making the diagnosis of ascites, the cause of ascites. Second thing which you will have to see is CT scan of abdomen. If you are suspecting any carcinoma, if you are suspecting malignancy, metastasis, then go for CT scan of abdomen. Apart from this, then you will have to go for upper GI endoscopy. In GI endoscopy, you will have to look for varices. If esophageal varices, gastric varices, duodenal varices, these are present, then that is suggestive of portal hypertension. So upper GI endoscopy, USG of abdomen, and CT scan of abdomen. These are very helpful in making the diagnosis. If you are suspecting liver pathology, from USG, CT scan, then go for liver function tests. I have already talked about these liver function tests in my previous lectures. So you will do liver function tests. After doing all this, if you are suspecting heart as the cause, then go for echocardiography. Hormonal estimation in cases of hypothyroidism. In case of tuberculosis, you go for TB IGRA test. You can go for PCR test for tuberculosis. So these are all the tests to make the definite diagnosis. If you are suspecting kidney disease, go for kidney function tests, renal function tests. The most important part of clinical approach is study of ascitic fluid. You will have to drain ascitic fluid and then you will have to study ascitic fluid. In study of ascitic fluid, first you see what's the color of the ascitic fluid. If say the color of ascitic fluid is bilious or it is dark, then that is suggestive of some rupture of gallbladder or obstructive type of pathology in biliary system, which has led to leakage of bile salts in the peritoneal fluid. So if it is dark colored, it is deep yellow in color, then that is suggestive of biliary ascites. Sometimes ascites is hemorrhagic, it is red colored. Now, this red color in the ascitic fluid, it may be because of two things. One is traumatic, and second one is because of some carcinoma, or even in pancreatic ascites, it is pancreatic acute pancreatitis, it may be hemorrhagic. In cases of traumatic ascites, the you will get blood clots in the ascitic fluid, while in the cases of carcinomatous ascites or carcinomatosis, or in case of acute pancreatitis, the blood will not clot in the ascitic fluid. If ascitic fluid is clear, if it is clear, that means there is no infection inside it. So such type of ascites is usually seen in cases of cirrhosis, in cases of portal hypertension. If it is pus-like, that is suggestive of peritonitis, pyogenic infection. If it is chylous, that is suggestive of triglycerides in the peritoneal fluid, in the ascites. So like this, one by one you will have to see. If it is yellowish in color, it is serous in color, then that is suggestive of tuberculosis, Koch's abdomen. So first of all, you see the color of ascitic fluid. The second thing which you will have to see is serum albumin and ascitic fluid albumin gradient. This is known as SAG, SAAG. If this SAG, that is the difference between serum ascitic fluid and serum albumin and albumin level of ascitic fluid, the difference between two is known as serum albumin ascitic fluid gradient. Whenever this gradient is greater than 1 or it is 1, then it is suggestive of portal hypertensive ascites. If this gradient is less than 1 gram per dl, 1 gram per dl, if it is less than that, then it is suggestive of non-portal hypertensive ascites. So like this, you will have to first see the SAG, and after that you calculate the protein level in the ascites. The protein level of ascites, if it is greater than 3 grams per dl, then that is suggestive of high protein ascites. That is known as high protein ascites. If it is less than 3 grams, then that is suggestive of low protein ascites. Now you will have to see what is the level of SAG, whether it is greater than 1 or it is less than 1, and what is the level of ascitic fluid protein, whether it is greater than 3 or less than 3. Usually when ascites is of high protein content, that is high protein ascites, then in those, and SAG is high, both are high, that is SAG is greater than 1 and protein in the ascitic fluid is high, then such type of ascites is usually seen in cirrhosis. It is usually seen in Budd-Chiari syndrome. It is usually seen in myxedema. So these are the conditions where this type of ascites is present. Cardiac ascites, again in cardiac ascites, serum level of protein is more. Sorry, I said that in cirrhosis, not in cirrhosis. In cardiac ascites, because of dilated cardiomyopathy or any valvular heart disease, if liver is congested, then in those cases SAG level is high, that is it is greater than 1, and level of protein in the ascitic fluid is also high. So this is high SAG and high protein ascites. So these are the conditions, that is cardiac conditions, myxedema in these conditions, in acute Budd-Chiari syndrome, in these conditions usually high protein and high SAG ascites is there. Whereas if protein is low but SAG is high, low protein and high SAG, low protein content and high SAG, that is SAG is more than 1 gram per dl and protein content is less than 3 in cases of cirrhosis, in chronic liver disease, in chronic liver disease, in chronic hepatitis, in any such condition, the SAG level is high but the protein content of ascitic fluid is low. So like this, you will have to decide whether it is high SAG or low SAG, high protein content or low protein content. In some conditions, the protein content is low and SAG is also low, both are low, then this type of condition is usually seen in nephrotic syndrome, where both these things are, SAG is also low, it is less than 1, plus the protein content of ascitic fluid is also low. So this suggests that there is some nephrotic problem, there is some problem related to kidney. Sometimes high protein content is there but SAG is low. Protein content is high but SAG is low. SAG is less than 1. Then this type of ascites is usually seen in tuberculosis. Usually in tuberculosis you will get this type of ascites. So like this, ascites can be, cause of the ascites can be detected with the help of proper examination of the ascitic fluid. After doing this assessment of protein in the ascitic fluid, after assessing the serum albumin, then you will go to the cell count. Usual cell count in ascitic fluid is less than 250. If it is greater than 250, then it usually suggests that there is some infection in the peritoneum. If it is between 250 and 500, then that if such type of count is present, then that is suggestive of spontaneous bacterial peritonitis, SBP, in cases of chronic liver disease. If count is more high, then that is suggestive of either perforation or some other infective pathology. You will have to go for culture and sensitivity of ascitic fluid, for cytology of ascitic fluid. In cases of carcinoma, you can detect the carcinomatous cells in the ascitic fluid. Gram staining, this is also necessary in the ascitic fluid study. Amylase levels in the ascitic fluid. If amylase levels are high, then that is suggestive of pancreatic ascites due to acute pancreatitis. If bilirubin levels, bile salts, are present in the ascitic fluid, that is suggestive of some pathology which has led to perforation in the biliary system, in the gallbladder, that will lead to biliary ascites. If triglyceride levels are high, you will estimate the levels of triglycerides in the ascitic fluid, then that is suggestive of, this is also known as chylous ascites, and it is because of high triglyceride levels, hypertriglyceridemia. Then in the cases of Cox abdomen, you will go for the study of adenosine deaminase in level in the ascitic fluid. If it is high, then that is suggestive of Cox abdomen. So like this, one by one, you will have to go for the study of ascitic fluid, and with the help of this, you can know the cause of ascites which is leading to the illness in that particular patient. I think so. This particular topic which I have taken in this lecture will be very helpful to the undergraduates, to the postgraduates, to the practicing doctors who are preparing for the entrance examination of post-graduation. They will be helped with these lectures. Thank you.